Good afternoon, Kenny, Pete from Wolverhampton University.
Good afternoon, Matt.
Good afternoon. You've been using associate clinical educators and simulated patients for some time on your course. What do you find the benefits of these are?
Well, thanks, Matt. I've been in undergraduate medical education for quite a long time, and learning to be a doctor or clinician, and one way of looking at it is a simulation of increasing fidelity. So you go from a paper-based simulation, a case, or whatever, problem-based learning through to working in a clinical environment. And a very important component of it is confidence. And students can learn. I mean, students learn from patients, obviously under COVID, and bringing in, there are issues around bringing in people with real pathology, for example. Students can learn, but it's not consistent, and the feedback. So the more opportunities to learn. Students do need to work with patients eventually. I've experienced of working with actors in the past, and again, you can have a consistent performance. They might be limited in their capacity to sort of extemporize, for example, and depending on how the conversation's going. So what ACEs, I think, do, they breach that schism between simulation, whether it's an actor, paper-based, and real people. And one of the most powerful drivers to learn is good, meaningful, immediate feedback. So you've got the consistency, you've got the fidelity, and you've got the feedback. So they really are a fantastic resource and a really powerful driver to support learning of clinicians.
Brilliant, brilliant, thank you. And what do you find, Pete, the feedback from the students actually is to you when you use associate clinical educators?
The students like the work we do with the associate clinical educators, and they feed back to us that sometimes they will admit to deficits in their knowledge that they wouldn't necessarily admit to myself or Professor Langlands. They feel a little bit that they're in a safer environment. One of the things to remember, if you'll indulge me, Matty, is that I grew up with associate clinical educators with University of Birmingham, so I haven't got the perspective that Kenny has, Professor Langlands, with other forms of training, but the ACEs provide something else. They're trained in clinical examination, and in terms of the dance, the technical stuff, not necessarily the diagnosis, but going through the methodical examination procedure, they can be better. They can demonstrate pathology. I know some of your associate clinical educators can demonstrate things such as unequal chest expansion. And also they are trained to give feedback in real time to the students. Essentially, they're added value.
Yeah. Okay, fantastic. When's the best time to use these within the 2-year course? What do you find? Who's best, Kenny?
Well, again, I know where you can look at this. I mean, the students need to be confident. So say, for example, you hear about medical courses with early clinical exposure, that if you put someone in a clinical environment when they're not ready for it, that it can have huge effects on confidence. So I think once the students are introduced to some of the ideas, the sooner the simulation increases in fidelity, the better, to an extent. I know there are arguments that simulation is not as good as the real thing, but one of the things we can certainly do by early exposure to ACEs is to make sure that the students do get into the clinic, that they're primed and are ready to go.
Right.
That's the thing. And so what it does, rather than being a substitute for learning in the clinical environment, because learning with and from patients is critical, it gives the students a head start. And Pete alluded to this. One of the most important things is students' confidence and students' perceptions of their own readiness. I think that the interaction they have with ACEs is different, as Pete says, the interaction they have with us, and the interaction perhaps with a less well-trained actor.
Yeah, that's a good point. And so, at the end of the course, end of the 2 years, you obviously got your OSCEs. So, where does the ACE or the simulated patient come in to its own there.
Would you mind if I?
Go ahead.
So we've recently used ACEs for our summative OSCEs at the University of Wolverhampton, and we have sort of a symbiotic relationship with the ACEs. For instance, we role-played a patient with manic depression, and there were certain clinical clinical manifestations that this patient classically had to present. So we work with the patients to get them to present like a manic patient. And because of their acting background and their dual clinical background, they're actually able to do this very, very competently.
So what's the difference between that and perhaps, moving away from the OSCEs now, but taking somebody that's got pathology and is a layperson who, you've taken out of the hospital and you've asked them to come along and just be a patient. So they have no acting skills, they have no medical knowledge, and they're patients, they're true patients, they have some pathology, and you can use them. They're often free, aren't they? So why wouldn't you just use lots of those?
Well, I think you want a pool of patients who want to get involved with clinical education is really important. But there are issues of bringing people in who are ill and then making them perform for a whole day.
Yeah.
COVID, it'd be unthinkable, I think, for us to bring in patients. So the ACEs were certainly very, very helpful. And the issues about consistency and about fairness. Now, exams are artificial and they're not the be-all and end-all. But the more resemblance they bear to the learning and education, the better, more confident we are about the decisions we're making. But if you're bringing in if you're doing it at a large scale in an undergraduate medical school where you've got multiple circuits running, students are all having a different experience, then there are issues around fairness and consistency as well. But you can't skip the fact that students need to be able to recognise uncertainty and complexity before what we're taking. And the exam isn't the end. In some ways, it's just the beginning. But hopefully students are primed for that, the uncertain world that they're going into.
Sure.
I add to that very slightly. The research also suggests that patients with a known clinical pathology volunteering to be expert patients, as we call them, it often correlates with them having an axe to grind about unfair or suboptimal medical treatment. So though we can value a patient, for example, having aortic stenosis, because we couldn't get an ace to play having an aortic stenosis, a systolic murmur. Sometimes when we get patients in with these pathology, they're in for own personal reasons where that doesn't occur with an ace.
Fair enough. Yeah. Okay.
I think just one last point is might be interesting for Meducate to think about. We need to prepare students for this complexity, and we need to prepare them for the population they're going to serve. And the individuals who put themselves forward to be expert patients tend to come from quite a narrow demographic, both economically, ethnically, socio-politically as well.
Particularly in Wolverhampton.
Indeed, so do our ACEs, again, no disrespect, but do they reflect the population our students are going to see? So going forward, I think medical, clinical training, we have to prepare students for the world they're going into and prepare them to be safe practitioners.
May I add something? We're trying to create at Wolverhampton, and since Kenny has been here, we've had a lot more support in this actually, a fine to fail, but essential to correct environment. So the clinical placement environment, it's very competitive to get students in there anyway, and it's high stakes. So if we create a fine to fail, high fidelity, as Kenny said, clinical environment within the university where students can make mistakes and be corrected in real time, it definitely adds value to their training.
Well, thanks very much for giving us a little bit of your time. Much appreciated.
Thank you for having us.
Thank you very much.